Welcome to Controversies in Cardiology. My name is Dr. Daniel Simon. I'm the president of University Hospitals Case Medical Center. Today I'm with Dr. Sahil Parikh, the director of the Center for Research Innovation in the Harrington Heart and Vascular Institute. He's an expert in vascular medicine and endovascular therapy. Welcome, Sahil.
Thanks, Dan.
Today we're here to talk about anti-thrombotic therapy in PAD. Do we need more than aspirin? What do you think about that, Sahil?
Well, I think that we are at a dawn of a new era in the treatment of PAD. Peripheral arterial disease has long been a vexing problem. It is one of the cardinal manifestations of atherosclerosis, but it's woefully underdiagnosed. In the United States, the estimated prevalence is about 17 or 25 million people, depending upon your estimates. And in our cardiovascular practice, we expect to see about 30% of our patients in the adult cardiology having peripheral arterial disease on an everyday basis. Unfortunately, when we look at our retrospective reviews of our patient populations, only about a third of those patients have actually carried a diagnosis of PAD. So there's a lot of patients walking around with occult peripheral arterial disease. When we find PAD, the mortality risk that's ascribed to panvascular atherosclerosis, particularly from heart attack and stroke, is astounding. In fact, a patient with a positive ABI has the same risk of mortality from cardiovascular disease as the very highest group of patients in the Framingham Risk Assessment. So PAD equals CAD, and in fact confers even higher risk than the garden variety patient with myocardial infarction.
You know, Sahil, I recall from the REACH registry that your 10-year risk of major cardiovascular morbidity and mortality is about 50% if you had PAD.
That's correct. And so the amount of peripheral arterial disease and the burden of atherosclerotic events is enormous in our country, and it's a huge public health problem, and it's something that to date has really not had specific therapies. When we talk about arterial disease in all of the beds, cerebrovascular, coronary, and peripheral, for coronary disease we have terrific therapies that subsume antiplatelet, anti-thrombin, and myocardial protective strategies. For cerebrovascular disease, similarly, there's been a lot of attention focused on it. But for PAD, it's really been an orphan area in that specific medical therapies have been woefully inadequate.
So we know that statins are beneficial. We know that aspirin is beneficial, but now we have a new study. So let's turn to that. So Pegasus, a great new sub-study from the Pegasus trial, suggests that aspirin may not be enough. Take us through Pegasus. What is this about adding ticagrelor to aspirin? Is it helpful in our patients with PAD?
Right. So Pegasus was a trial of over 20,000 patients looking at their ability to tolerate and what benefits may occur if they take long-term dual antiplatelet therapy with aspirin and ticagrelor. The inclusion criteria were patients with prior myocardial infarction up to 3 years prior to enrollment, and then sustained therapy with dual therapy for up to 36 months. That included patients who had prior PCI or medical therapy for myocardial infarction. These patients, as you can imagine, were enriched for having panvascular disease, and in fact, over 1,100 patients of the overall 21,000 had peripheral arterial disease identified at their index inclusion into the trial.
Great, and so I recall that Pegasus actually was a 3-arm study. So it tested 2 doses of ticagrelor, 60 BID and 90 BID, in addition to aspirin less than 162 milligrams. So what did we learn in this very important PAD subgroup?
Right, so for the main findings were that if you pool both the 60 and 90 BID patients and compare them to placebo, which was aspirin monotherapy, there was a substantial reduction in major adverse cardiac events, as was consistent with the clinical trial itself. And more importantly, there was actually, for the first time, a signal suggesting that there was reduced limb events. In fact, there was a 10-fold reduction in major adverse limb events over the time of the study, and there was a dramatic reduction of almost 25% absolute risk in terms of revascularization. So there was a substantial reduction in limb events, acute limb ischemia, revascularization, and the need for any kind of revascularization in the extremities. It was a dramatic finding, and it's a real first in peripheral arterial disease medical therapy.
Wow. So take me through. So one of the things that I do recall is that even in the Pegasus trial, the presence of PAD was associated with increased MACE overall.
Correct.
So what was the difference between people with and without PAD?
So in the trial as a whole, taking all comers, there was an absolute risk reduction on the order of 1%. when you look at the PAD sub-study, the risk reduction was on the order of 4%.
Wow.
So a fourfold magnification of this beneficial effect in the reduction of MACE.
So PAD is a marker for probably more extensive and severe atherosclerosis.
That's what we believe.
Okay, so there's an effect on limb events, something called major adverse limb events, or MAL. I don't really know what those are, so try to enlighten our predominantly cardiology audience.
Right.
What are MAL events?
Right. So we have, for a long time, looked at MACE, major adverse cardiac events. Here, you're looking at limb events which include acute limb ischemia, as well as the need for target lesion revascularization or target vessel or limb revascularization. And so patients who have, for example, in situ occlusion of a major peripheral artery will develop peripheral ischemia based on that, and a revascularization event based on that, which in Pegasus was independently adjudicated by a clinical events committee, would count as an event. And so these are events that to cardiologists are frequently occult, because we don't do a great job of looking at our patients' feet in their physical exam.
Right.
But certainly in this study, they were carefully adjudicated, and clearly there's a major difference between the two groups, one that is both statistically and clinically significant.
Okay, so obviously whenever there's a benefit, as our old boss, Dr. Bromwald, used to say, there's no free lunch with anti-thrombotic therapy. Tell me about the bleeding side. So 60 BID, 90 BID, what's the bleeding, the net benefit, so to speak?
Right, so the interesting thing was, in this cohort of patients, the PAD patients, the number needed to harm was over 880. So the relative increase in bleeding was 0.12.
Wow.
And so very, very low hazard and a small price to pay, if you ask me, for a major reduction in clinical limb events. So again, where one would expect a greater bleeding hazard with a more potent P2Y12 blocker, here that signal was not borne out. And again, larger studies would probably be needed to really flesh this out better. But the signal seems very strong, and the data are compelling for changing how we practice.
Okay, so you're saying that big benefit on the ischemic limb side, very little price to play in bleeding, so therefore practice changing. So I guess the question of the day is, in your patients now with PAD, are you advocating dual antiplatelet therapy?
Well, so I would step back from that just a little bit, because the inclusion criteria for Pegasus were patients with prior myocardial infarction. So these are the true pan-vascular patients who have events in multiple vascular distributions. And so in those patients, my practice now is to maintain DAPT with aspirin, 81 milligrams typically, and ticagrelor, 60 milligrams BID. We are going to encounter challenges with that, as the word is not yet on the street, and we look forward to further educating the population about this. But I think that there is significant benefit, and it's difficult to ignore the large benefit clinically and the low price to pay.
Great. Okay, so now, of course, it leads to immediately a host of other questions, which we can try to rifle through pretty quickly. So there are other antiplatelet agents. Let's start simple first. What about just adding clopidogrel? It's generic. It's going to be cheaper. What about adding clopidogrel to aspirin instead of ticagrelor? What is the data about other P2Y12s?
So clopidogrel has, for a long time, actually been indicated for secondary prevention in PAD. In Capri, there was a significant reduction in limb events and PAD events that was statistically significant. And in fact, this data has been out there for almost 2 decades. And so clopidogrel has been a mainstay of therapy as an alternate to aspirin, but not perhaps in addition to aspirin. Forthcoming in the next 12 months, we expect the study results from Euclid, which is a study comparing ticagrelor monotherapy and clopidogrel monotherapy head-to-head. If one believes that clopidogrel monotherapy, as we know from Capri, is beneficial, is TICAG superior when compared head-to-head? Over 13,000 patients were randomized, and we look forward to seeing those results, both with respect to peripheral and major adverse limb events, as well as cardiovascular events. So stay tuned. I think those data are pending at the American Heart Association this year.
Great. So this is actually a pretty trial-rich area right now of great interest. Now, I guess the final areas that we have to cover are, what about PAR1 antagonism? So this is the thrombin receptor. Vorapaxar has an indication, as we recall, for post-MI and in patients with PAD. Of course, it's based on subgroup analysis because the stroke group and TIA group were thrown out for increased fatal intracerebral bleeding, but there is an indication in PAD and MI. What's Vorapaxar's role in PAD?
So the problem with it is that many of our patients have panvascular disease, and they have solid indications for aspirin therapy and for potentially P2Y12 blockers, as we've already discussed. So in the setting of these patients, it's difficult to justify addition of a third agent, particularly given the bleeding hazard that's been seen in clinical studies. So you're looking at patients with so-called isolated PAD, where in fact those are fairly few in my practice.
Right.
And so we're having a difficult time identifying which patient population would be appropriate. There are patients in whom, just akin to what we've seen in Pegasus with ticagrelor, there's a clear reduction in major adverse limb events when one compares patients on aspirin therapy to those on Vorapaxar. But again, I think right now it will be in those patients who are medically managed for peripheral arterial disease longitudinally, who don't have a need or a compelling need for P2Y12 blockers and aspirin. Right now, with the data that are currently in hand, it's a little bit difficult to know which patients those are. There's also great concern, and many of us, myself included, share this concern, that bleeding is not fully understood. And whereas the number needed to harm in Pegasus was a vanishingly low number of 0.12%, we are much more worried about what the real-world data will be with Vorapaxar.
Yeah, I mean, I think it's also really important to emphasize that the subgroup of Pegasus was only 1,000 patients. And so it'll be very interesting to see how this plays out in terms of guideline recommendations. I think most of us probably expect it's going to take a dedicated PAD trial for a class 1 indication. But it certainly makes sense in a post-MI patient to consider DAPT now. I guess the final issue, and we can't leave our listeners and readers without this, is we encounter very frequently that patients with PAD aren't on statin medications. So just take us through traditional guideline-based therapies for PAD. So obviously aspirin, but statins, there is a good bit of data about statins.
Strong evidence base for almost all of the risk factor modifications that we would conduct for coronary artery disease. It's entirely analogous in PAD. So first I would say that smoking cessation, aspirin monotherapy, and or clopidogrel as an alternate are class 1. In addition to that, medical therapy of blood pressure to target. LDL goals that have been set in the PAD guidelines specifically are 100 milligrams per deciliter. Whether or not you believe that we should be checking levels, that is the current state of affairs with guidelines. And statin medications are a class 1 level of evidence A indication for patients with PAD. The new guidelines, which will be published this year in 2016, are expected to be rolled out at the American Heart Association. And interestingly, the Euclid trial will be presented almost at the same time and will have consequently missed the guidelines. So the new guidelines for PAD, which will be revisited for the first time in almost a decade, are likely to have indications for statins, blood pressure control, all of the other risk factors that we consider traditional risk factors, but there will still be the void of potent P2Y12 blockade. And so that will be something that we look for in the update to the guidelines, which we don't expect for another 2 to 3 years.
Yeah, and it'll be really interesting. Obviously, we're in the house of Jackson Wright, today here at University Hospital. So it'll be very interesting to see a PAD subgroup analysis of the SPRINT trial. Is 120 better than 140 in patients with high risk or have coronary disease, but also have PAD checked off? So we'll have to wait and see. Right. Well, all I can say is thank you so much for teaching me. You haven't lost your Chief Resident Mass General credentials yet in my book. I always learn from you. I want to thank our listeners today for tuning in to Controversies in Cardiology, Anti-thrombotic Therapy in PAD. Do we need more than aspirin? And I think the answer from today is most likely. Thank you very much.